Fortunate to be offering this webinar to you today. I'm Stephen Davidow, President of the Illinois Association for Healthcare Quality. I also am Director of Quality Improvement at the PCPI Foundation here in Chicago. Before I introduce our speakers, I did have a few housekeeping slides to go over with you. I wanted to let you all know that we have set the date for the annual conference, which is Tuesday, May 7th. It'll be held at the NIU Naperville campus in Naperville, Illinois. And of course, we'll have a wonderful keynote address, panel discussions and sessions. We'll have our second quality improvement poster competition. We'll also be, of course, providing CPHQ continuing education credit. And there'll be plenty of opportunities for networking. We'll have a reception and many sponsorship opportunities and much more. So please continue to keep an eye out for announcements that we send out, as well as have on our website about the conference. You should also be aware that there are many opportunities to engage in the association through education and programming work, planning for the annual conference, supporting membership and nominations for various committees, our communications work, our technology for the new website that we have, also soliciting sponsorships, and our awards work. And if you are interested in any of those activities, please send an email to info@IAHQuality.org. I just want to remind you all that today's webinar is being recorded. The recording will be posted on our website, and a link will be shared in the next IAHQ news. Please use the chat box or window for your Q&A session after the formal presentation. You may submit your questions throughout the presentation, and we'll address those questions during the Q&A. And that will also, for those who request it, send out certificates for 1 hour of CPHQ, CE continuing education credit, and those will be emailed using the address that you provided when you registered. So a quick introduction for our speakers today. We're very fortunate to have Jonah Stulberg from Northwestern University Feinberg School of Medicine, as well as Julie Johnson, also from Northwestern University Feinberg School of Medicine, to talk with us about this important topic and the work that they've been doing. And I look forward to their presentation and also all of your questions during the Q&A. I think this is an important topic, as we all know, and this is important work that they're sharing with us and that we can all learn from. So with that, I will turn it over to our speakers.
Great. Thank you, Stephen, for the invitation, and thank you everyone for logging in and taking an interest in what Julie and I clearly feel is an incredibly important topic, and that is how we all, as providers, as administrators, and as those interested in healthcare, can improve opioid stewardship amidst a crisis, which we all clearly identify that we are in. I will just mention that I am a general surgeon. Much of my thinking efforts and our research to date has been focused around acute pain management and the surgical practitioner. So this will be focused in that area. Let me see if I can click and then advance. Doesn't look like it's advancing. There we go. Maybe I have to request again. So here are our disclosures. Julie and I are, Dr. Johnson and I are co-principal investigators on an NIH-funded grant. I have other grants, as well as I do some teaching and consulting for Intuitive Surgical, none of which will be directly influencing today's talk. So I start by saying that I think one of the reasons why everybody's logging in, and 5 years ago we probably wouldn't be logging in, is because the opioid crisis and this concentration of what healthcare may be doing to perhaps worsen or drive this crisis has been a real frenzy in the popular press media. And so you can see this is just a random assortment of clips of newspapers and other lay media outlets from 2013. And really in the last 5 years, this has really escalated to a level that I think none of us were really prepared for or could have foreseen. And all of this press and attention is for good reason. It's because when we look at the leading causes of injury-related death, and this is just a rough overarching look at death rates. So you can see death rate is on the y-axis over time. If we go back 20 years to the late 1990s and around 2000, drug overdose deaths were far, far lower than deaths from motor vehicle crashes and gun violence. And there was a big push and efforts made to address motor vehicle violence. There's also been a lot on gun control, but as we know, those have not been terribly successful. But drug overdose deaths have really taken off. And you've seen them continue to increase past even what this graph demonstrates. So it appears I show meeting control. Let me try and sorry, I'm having just, there you go. If we look at age-adjusted death rates of drug overdose and drug overdose deaths involving opioids, we see that rapid climb in overdose death is driven by opioid deaths. And further, if we dig one level further, if we say, well, opioids involve a lot of things. We've heard of, illegal synthetic fentanyl coming over the borders. We've heard of injectable opioids that are street drugs. But if we look at what we have control of as healthcare providers and as hospital systems, as pharmacists, we have control of prescriptions. And if we look at prescription opioids and prescription opioid death, you see that it absolutely mimics this. So deaths from prescription opioids have also continued to rise. And so it's no surprise then that if we map the opioid death rate per 100,000 and the opioid sales rate per 10,000, we can see that these really do map to each other. And so I think there's this general consensus and general feeling that we as healthcare providers and as healthcare systems are clearly playing some role, and we need to look at our own prescribing behavior, and we have to figure out how we can stop playing a negative role and start playing a positive role. And one of the things I think is difficult when we look at the headlines and we look at these big data explorations and we see these huge trends is trying to understand how this applies to us. So I want to provide you with one patient experience. And actually, this is an absolutely 100% true story. It's actually my mom's story. This is from 2017. So just this past, just last year. She had to undergo a thumb surgery. And so on March 23rd, she had a relatively minor procedure. The procedure was done as an outpatient. She did not require a general anesthetic, so she was sound asleep. She was not asleep during the procedure. She was awake talking the whole time. The whole time she said she was numb. She didn't feel a thing. They had done this block. They had taken care of all of these measures around the initial time of surgery to help manage her pain. And then they discharged her that same day, and they sent her home and they wrote her for a prescription for 30 Percocet. So then she had to get a procedure done, an oral surgery procedure. She actually had an implant. And so as anyone knows from those implants, that one you can't talk through. You are more asleep. They can be quite painful. But that was really just over 2 weeks. It was really about 3 weeks after her thumb surgery. And on discharge, the oral surgeon prescribed her 30 Percocet. So now she's got 60 pills. And a couple months later, in June 7th of that same year, she had to just have this thing removed from her toe. Again, she talks about minor procedure. They did it all under local anesthetic. She talked through the whole thing. She was awake. She had no pain. She felt great. And as she left, she got another prescription for 30 Percocet. So if this was a live audience, I'd ask all of you, how many do you think she took? And I gotta say, I gave this presentation and told this story in July of 2017, the first time. And the overwhelming majority of the crowd said she probably took between 60 and 90. just through the awareness of what's going on from headlines, from different speakers, from all the talks that various people hear, the average number of pills that people think she took has come down. And most people at this point think she took between 15 and 30 probably. The reality is that she took 0. She took none of her Percocet. She's a nurse by background. She took Tylenol, ibuprofen, used ice, and then said she actually never needed anything on top of that. So, but she now, if she went and filled all those prescriptions, would be sitting at home with 90 pills. And I bring that up because there's a very important percentage out there that we haven't yet talked about, and that's 10%. 10% of, whoops, sorry, I jumped ahead. 10% of the pills typically prescribed by surgeons and proceduralists, so I would include dentists, I'd include podiatrists. 10% of those pills on average go unused. Now, it turns out we have made some progress in this area. So now the number in more recent studies is more like 20% because the number we're prescribing is going down. And I've even seen 25%, but I got to tell you, that is still a minority of the pills that are being used. And the other thing is that 10% of the opioid prescriptions written in the country are written by surgeons. So interestingly enough, 10% rings true for a couple of things. And that is important because the single biggest driver of non-medical use is diversion. And diversion is simply use of a prescription medication, a lawfully prescribed prescription medication, by the unintended user or by that same user for the unintended purpose. So you give someone a prescription for their thumb surgery, but they use it because they have back pain 2 months later. This has been shown now in the data. Patients prescribed opioids after outpatient orthopedic surgery, and this is repeated in gynecologic surgery and thoracic surgery and general surgery and across the board, really. We see that on average, far fewer pills, and that's this big green one over here, far fewer pills, between 0 and 5 pills are typically used, even though the average prescription is 30 plus. And that first real paper was in 2012. And so another important manuscript that I bring your attention to is the one by Jones in JAMA Internal Medicine 2014, and it's the data behind where non-medical use comes from. And if you look at the data here, this gray bar is just given by a friend or a relative. So the overwhelming majority of users, of non-medical users, whether they're using a little bit or a lot, if you look at this any category, the overwhelming majority of non-medical use is from people who just borrow them from friends or family or are given them. So those two stories together are a pretty short path between how surgeons and surgical providers and those who are treating acute pain are having an effect today on overdose, abuse, and misuse. And that's that overprescribing can lead to diversion, and those excess pills being readily available for non-medical use in many ways are fueling the current crisis that we have. A humbling statistic that has come from the CDC is that 75%, or 3 out of 4 heroin addicts, will tell you that they began by using prescription drugs. And now the latest number in this past year was 85%. And that may be going up simply because of the number of prescriptions that we have out there in society. So there is a very clear link, not only with then the prescription use and abuse in overdose from prescription drugs, but leading to heroin use and then overdosing from heroin or other street drugs. So with that data in our back pocket, Dr. Johnson and I applied for an improvement effort on ongoing research through a federally funded research grant, which was an R34 from the National Institute for Drug Abuse. And with that, I will turn it over to Dr. Johnson to explain more about our research efforts.
Thank you, Jonah. Thank you for that background. I've heard you give that many times, and I'm always, I find it very compelling as setting up our argument for why this is such an important issue for us to address. let me say a little bit about myself before I move forward. I'm Julie Johnson. I'm professor of surgery here at Northwestern, and my background's in clinical quality improvement and in patient safety. And so over the past several years, I've become much more interested in implementation methods and thinking about how we implement these quality improvement initiatives. And that's how Jonah and I came to work together around this issue. So in quality improvement, and I'm sure many of you will agree that we have this persistent challenge that we have to ensure the broadest adoption of evidence-based improvements in practice. But there's also this other goal is to motivate research into further improvements of processes and outcomes. So, and this is where I am kind of on this bridge between research and quality improvement, is that I want to work on the QI initiatives, but I also want to continue to do research. So what is the best way for us to actually implement these different ideas? Let's see if I can move forward here. I don't think I'm moving. Oh, there we go. All right, so implementation is a really important area to think about as we are taking on any quality improvement initiative. And an issue around improvement methods is that, you know, we have a host of different improvement methodologies. None of them actually incorporate a systematic approach to implementation. So you have to think about, you know, the work that we've done in improvement over, you know, the past 20 years. What we've really done is we've often failed to think about the best way to implement. And then when the improvement doesn't take hold or isn't sustainable, we have this incorrect conclusion that the solution that we tried to implement wasn't actually effective, when actually what happened was we had a failure of implementation. So, Stephen, if you could just move forward to the next slide. Thank you, that's perfect. So for example, we have, you know, at Northwestern, we use the DMAIC model, and I'm sure many of you also use that model. And next slide, please. What we're lacking here is around our, from our steps from define, measure, analyze, improve, and control, is this issue around identify and implement improvements. We list that as a big step, but actually there's a lot that goes into that step. So what is it that we're missing when we think about how we actually identify and implement improvements? It's the same with the model for improvement that the IHI uses. We have the steps of what we're trying to accomplish, how we know a change in improvement, what changes can we make that will result in improvement, and then we lead right into the PDSA cycle. But you know, what are the organizational changes that are going to be needed for you to actually to have success in your improvement efforts? So in improvement work, we have these underlying assumptions that the people who are supposed to be doing the improvement work have all the necessary intrinsic motivation. We assume because we want them to do it, then therefore they must, you know, be willing and eager to take on these improvement ideas. And we have this other assumption that there's this culture of excellence that exists in the organization, that they're going to be able to sustain any improvements that we implement. So we have some problems with our basic assumptions. So a colleague of ours, Rohit Ramaswamy, and I have been talking about this model for improvement and implementation. We really start to bring together and integrate what we know about improvement science and what we know about implementation science. So the left-hand side of the model shows the improvement questions that we're familiar with from the improvement model. The right-hand side of the model shows that there are actually implementation questions that we also need to be thinking about. So what implementation outcomes are critical to implementing the change? What factors impede the achievement of these outcomes? What implementation strategies are the most appropriate to address these factors? And those work in conjunction with the improvement questions as we're setting up to do our PDSA cycles. Now, one thing that I think is absolutely fascinating, we're used to talking about outcomes. We talk about you know, outcomes of our improvement work that we're measuring. How do we know a change will be an improvement? But we also have to think about implementation outcomes, and those are a different set of outcomes. So implementation outcomes will include things like acceptability or adoption, appropriateness, the cost, the feasibility. So is it feasible to actually implement these change ideas into practice? So those are the types of things that we need to think about when we are actually measuring the outcomes of our implementation of an improvement initiative. So our work, the grant that we were funded for is minimizing opioid prescribing in surgery, or MOPUS. It involves expectation setting, screening for risk, optimizing function, and monitoring and improving the prescriber and patient relationship. This research project has several different aims. First is to evaluate the implementation of this multi-component intervention. Our goal is to reduce post-surgical opioid prescribing. We want to make sure we have optimal pain control and have these user-centered iterative design sessions with specialty-specific multidisciplinary teams at 5 hospitals, and those are the hospitals within our Northwestern family. As far as thinking about the outcomes that we're measuring, we're assessing changes in opioid prescribing and pain-related patient outcomes following our implementation. And then finally, we're assessing the interaction between the site-specific contextual factors. So what is it that's going on at an individual hospital, on individual units that might have an effect on how you're able to implement? So assess that interaction between those factors and the variation in the fidelity to the intervention and the intensity of the implementation on post-surgical prescribing. So our system-wide improvement project, and this is where we start to bridge this gap between thinking about implementation and thinking about improvement, then is to work on safe disposal of opioids, and we're doing that through kiosk and med disposal kits, as well as a take-back day. Patient provider education, so we've created modules on safe prescribing, and also some materials for patients around education around opioid use and disposal. We've made changes to our EMR, and also around measuring and reporting, so developing an automated reporting system so that we can give clinicians data on their compliance with the opioid prescribing guidelines. Now, kind of going back to our ideas around the research project, we have, we're evaluating the project, we have qualitative measures. In our qualitative methodology, where we've been conducting interviews with surgeons and pharmacists and nurses and anyone else within our system who might have some effect on the prescribing of opioids or in working with patients and getting them to return them. We've been doing some focus groups. We will be conducting patient interviews. This is still, work in progress. And we've also been conducting some observations in our clinic. So in the pre-op clinic, for example, we've been shadowing the nurses to better understand when it is that they're providing patients with information about opioids, or how they're talking to patients who are preparing for surgery, asking them, about their experience in taking opioids previously, or if they have any questions about them, or if they understand the risk of taking opioids. Our quantitative methodology includes using patient-reported pain outcomes and an opioid use survey. We're assessing the readiness of the sites to actually implement the intervention, and this gets back to the implementation science approaches. So, trying to better understand if the site is prepared for the implementation, and if not, then what can we do to help them actually better prepare? Also, process measure reports and these automated prescribing reports. So we're doing a simultaneous mixed methods formative evaluation, and also eventually we'll be doing this qualitative comparative analysis, which is a way to bring together the qualitative and the quantitative data and better understand those contextual factors at the different sites, and which of those factors are most supportive of successful implementation. Now, today I'm able to give some preliminary findings. and this is from our qualitative data. So we've, as I mentioned, we've done several key stakeholder interviews to better understand what are their ideas about the barriers to implementing our intervention. And we've grouped those into 5 categories. So knowledge, so barriers related to knowledge, barriers related to social and professional role and identity, barriers related to the environmental context and resources, belief about the consequences, and behavioral regulation. We had the opportunity to talk to 23 people so far, and that includes surgeons, nurses, pharmacists, and administrators. In knowledge, what we found was that there was a lack of patient and provider knowledge of alternatives. And so that is something that highlights for us a need to strengthen that and to work on that as we're coming up with our solutions for how to tailor the interventions. In social and professional role and identity, one thing that we learned is that the pharmacists were not consistently integrated into the treatment team. And this is a huge opportunity. The pharmacists are incredibly knowledgeable about opioids and the use of opioids. And the ones we talked to are quite eager to be part of this initiative. So finding ways to integrate them into the treatment team and to better use their expertise. I need to go back. I wasn't quite ready. I'm not able to go back. So Stephen, if you could just move it back. Oops, not that far. Perfect. Thank you. And then environmental context and resources, a lack of adequate preoperative patient education. So part of in conducting the interviews and also in our shadowing in the pre-op clinic, we realized that this was an area that we needed to strengthen in our organization was making sure we had the right patient education materials available to share with the patients. This area about belief about consequences is a problematic area because we found that you know, on the one hand we have this idea that we don't want patients to be in pain, and so we've set up the patient expectations to think that they should be pain-free, and so maybe we've gone a little too far in that. So and then also we have this concern that, well, if patients have had pain or haven't been completely satisfied, then they would not rate so highly on their patient satisfaction. So how to think about setting appropriate expectations with the patients about pain and what they can expect while they're in the hospital after they've had surgery is something that we need to continue to work on and is part of our initiative. And then the behavior regulation is related to our changing the prescribing practices and making sure that everybody's on board with the appropriate levels of prescribing for procedures. And Jonah can talk more about this, about the work that we've done in setting those limits. So and surgeons have talked about, well, we don't know, in some cases they didn't know the appropriate numbers of pills to prescribe for a procedure. So making sure that information is available to everyone. And so here are some of our preliminary findings from the quantitative, and this is related to the patient phone survey. So we surveyed patients 30 to 60 days post-discharge, and these were patients from the Digestive Health Center. And also we conducted surveys from April to June 2018. There were 55 people who were able to conduct surveys with, and the response rate was around 27%. And what we found were that patients who received both the pre- and post-operative counseling on pain management were more likely to feel prepared to manage their pain. So this education piece is an important component. And so they were more likely to feel prepared to manage their pain compared to those who received it only preoperatively or post-operatively. So this combination, this 1-2 hit of the preoperative counseling and post-operative. Patients who reported feeling prepared to manage their pain used fewer opioids on average, and those who did not, 7 versus 10 pills. And 78% of patients who filled their opioid prescriptions had excess pills. So a lot of excess pills that are out there. Only 21% of the patients with excess pills reported disposing of these pills. So clearly, from our preliminary findings, we're seeing that we have work to do here. So our solution we like to think of as being comprehensive, that we're working preoperatively, perioperatively, and postoperatively. I want to hand it back over to Jonah, because he's going to talk more about the improvement work in the initiative from that perspective, now that you've gotten an idea of the type of research that we're doing to support our improvement work. Jonah? Jonah, are you there?
Yes, hi, I'm here. It didn't sound like people could hear me. Sorry, I'm going to try again here. Let me request
Yes,
one more
please.
time. Sorry, yes, I am here, and I now have control. So thank you, Julie, for that summary of some of the research components. I think as Julie mentioned a couple of times, and I think it's critically important as we're talking to a healthcare quality organization, that we think about the quality improvement and research efforts that we do fitting into the grand scheme of everything our clinical providers have to deal with on a day-to-day basis. So, you know, one example of that is how our MOPIS intervention, how our interventions fit in with enhanced recovery after surgery interventions. And as many of you are, I'm sure, implementing in your hospitals, we've been implementing sort of comprehensive enhanced recovery pathways starting in colorectal and then branching out to surgical oncology and thoracic and all these other service lines. And so when we come and we say we want to talk about pain management, we want to talk about discharge prescribing, one of the big questions is, well, how does this fit into all of those other efforts? And this slide is supposed to kind of give a graphical representation of the fact that this is in many ways either a wrapper, you could think of it as a wrapper, or seamlessly integrating in the components which we feel aren't necessarily typically the focus of an enhanced recovery pathway. But you could see the same thing having to occur with any quality improvement effort that you're trying to undergo at a hospital. How does surgical site infection prevention dovetail with the fact that I also have to worry about VTE prevention or other efforts? And so it's really important to understand that what we're talking about is not a replacement of these other efforts, but it's a complement to those efforts. And this slide was specifically helping providers understand that in our hospital. And so now I wanted to spend some time, given the audience, I wanted to spend some time specifically talking about the quality and the implementation of the quality improvement components into clinical care. So we categorize them under minimizing opioid prescribing and surgery. One important focus there is that what we're talking about is decreasing prescribing at the point of discharge. Pain management comes in many different flavors. Enhanced recovery has a lot to do with sort of nutrition, for instance, and activity after surgery. Some of those things might help with pain control, but they also are not specific to sort of prescribing. So as we think about how do we minimize our prescribing practices as surgical providers, we still want to take a comprehensive look. And we bucket this into four areas. We talk about changing our conversation around pain expectation setting, actually doing formal risk screening, because many of us don't. It's sort of part of like social history. Do you smoke, drink, or do other drugs? Okay, move on. When really we should be doing more. And by doing more, we can have really great benefits to our patients and understanding how to appropriately manage their pain. The next is talking about pain as an optimizing function. We want to control pain enough so that we can optimize function. And by switching that conversation to something around function rather than those smiley faces that you see at the bottom, I think it changes the focus of the conversation that you have, and that's particularly important in the inpatient setting. And then last, and certainly not least, probably the most important component is that traditionally we did not do a wonderful job of monitoring how patients' pain was managed after they left the hospital. It was sort of patients are on their own. You get a printout with discharge instructions, say, hey, go take care of it. And so we talk a lot about, in particular with scheduled medications like opioids that have known risk factors like of addiction, abuse, and misuse, how important it is to have that prescriber-patient closed loop around prescriptions. And we talk about several methods for doing that. So to dive into each one of those components, the first would be expectation setting. The typical conversation in most preoperative surgical offices goes something like this. There's low risk to the surgery. It's an outpatient surgery. You're going to go home afterwards. You'll do very well. I do this all the time. I'm very good at it. But the patient is often sitting there thinking to themselves, well, I'm pretty scared. This isn't every day for me, and I'm worried that surgery hurts. It turns out that there's actually evidence to suggest the single biggest question on most patients' mind before undergoing elective surgery is, how much is it going to hurt? And one of the most frequently skipped components of conversation in the preoperative setting by providers, nurses, and physicians is how we're going to manage pain. So we've developed a one-page document about setting appropriate expectations for postoperative pain and the best practices to doing that. Give people things to say so that they understand what language will help set expectations appropriately, put patients at ease with the anxiety around the fact that you will be managing it and how you manage it. Furthermore, we also know that a lot of the education that occurs in that often too rushed preoperative clinic appointment doesn't fully register. And so we want to give patients something to go home with. And we've developed a standardized handout. This is the one that we developed. We used at Northwestern. We actually have now taken the logo off of it, made it freely available through ISQIC. So many of our hospitals through our Illinois Surgical Quality Improvement Collaborative can simply download it and send it to the printer, put their color scheme or whatever on it, but it has language that's appropriate for a 6th grade reading level, and it has information about how to appropriately use medications, what an opioid is, and then how to dispose of it and how to correctly store it at home. So that's expectation setting and what we've done to support appropriate expectation setting. With regards to risk screening, we found this to be a harder hill to climb. There are some evidence-based practices for risk screening patients who are at risk for abuse and misuse of opioids. Many of those are better suited, quite frankly, to a primary care setting, and were meant in many ways in their development to be given to patients prior to initiating chronic pain management, prior to initial prescriptions around something that is thought to be likely a chronic pain condition. And so when we talk about risk screening for acute pain around giving a prescription or a new prescription for acute pain, we're left struggling for instruments and tools. One of the ones out there, which is relatively easy for folks to complete, it can be completed pre-operatively in the waiting room or things like that, is a simple questionnaire called the Opioid Risk Tool, which we make people we give to people and point them in that direction. However, what we found is even that seemed to be a lot for many of our provider practices to implement realistically into their workflow. And so we came up with something that's in what we call an ISQIC short screen, which simply asks them to correctly ask the question, how many times in the past year have you used an illegal drug or used a prescription medication for non-medical reasons? And just that question alone will then allow them to say, okay, if you're doing those practices, we need to reach out for help, because most of our surgical providers are not prepared to appropriately intervene and manage pain in someone who is either abusing or at least misusing these medications. So now in Illinois, I'm sure many of you are aware that as of January 1st, 2018, it became a state requirement that if you're initiating a prescription for an Schedule II medication, of which most opioids are, then you were required to look up that patient's record in the Illinois PMP. Many people are now pretty aware of that. We helped integrate it into our electronic management our electronic medical record here at Northwestern, and we've seen compliance for just checking go way up. When you make the barrier to accessing this information easier, it becomes much easier to make it part of your clinical practice. We still have one holdout state, and that's Missouri, our neighbor, that does not have a PMP, but all other states do. And actually, we're fortunate in Illinois that we participate in a sharing program. And so we have access to not only prescriptions written in Illinois, but through that, the portal can get access to prescriptions written in Indiana and Wisconsin. So this is what I was just saying, that our particular Illinois PMP actually is one of the best in the country. We get updated data within 24 hours because all distributors, licensed distributors, are required to upload all Schedule 2, 3, 4, and 5 medications. However, the search is for Schedule 2 and 3 medications, and it is reported on a daily basis. As of January 1st, 2018, this is the information that I just discussed. Oh, by the way, for those of you that are at hospitals where the PMP is not linked to the electronic medical record, it will be a requirement by 2021. So hopefully that's at least on all of your radars, because it can take a little while to figure out, depending on which EMR you have and the details of that, but getting it linked appropriately. So next I wanted to talk about optimizing function. Critical to the appropriately prescribing medications at the point of discharge is understanding how to manage pain around the time of the surgery. And so we have educational modules now that Julie referenced, but we have educational modules now that we've developed through a learning management system. They can be deployed, and you can walk through sort of our what we put forth as best practices around appropriate pain management. And this pyramid is part of that. And it simply says, you know, at the base of the pyramid should be those pain management strategies that have the least side effects, that are the easiest to tolerate. And if we think about how opioids fit into that strategy, oral opioids should come first, but you should not get rid of the base of the pyramid. You need that base. So you should continue your acetaminophen, your NSAIDs, your COX-2 inhibitors, or your alternative modalities in addition, and then layer on oral opioids. And then only if needed for acute pain in severe pain situations do we start to use IV opioids. And this has made a real culture shift in our hospital because PCA use, patient-controlled anesthesia use, analgesic use went way down after some educational interventions around just how those IV opioids do affect things like bowel function and ability to discharge patients on time. The other is that a lot of providers that tell you, they say, well, just tell me what to do, right? I just want to know. I'll do it. It sounds like a good idea. Fine. What do I do? And so part of what we've done through the toolkit and through our different interventions is to just give them protocols. Here's one protocol. This is for abdominal wall reconstruction, which involves a lot of muscular mobilization, which is where the gabapentin comes in useful. This is my protocol that I use in my practice. It starts with Tylenol, ibuprofen, and gabapentin. I always advocate for the infiltration of local anesthetic and coordination with anesthesia to minimize opioid use during the time of surgery. And then what do we do post-op? Well, here's a schedule. Schedule your Tylenol, schedule your ibuprofen, always use ice packs. These things help, and they give people the reassurance that you're focused on making sure they manage their pain appropriately. And then here's how you taper it off. So the next component of shifting that conversation to one of function and understanding what we do at discharge is simply giving people guidelines around the numbers of pills that should be prescribed at the point of discharge. And, you know, we went back and forth a lot, you know, whether we should use MMEs, morphine milligram equivalents, whether we should specify, well, this is what you write if it's oxycodone, this is what you write if it's tramadol. The reality is that most people just want a number. They know the pill that they like to use. They like to use oxycodone 5 milligrams. Okay. I like to use Percocet. Okay. But whatever it is, here's a number that you can latch onto. And we're starting to see some really incredible data through our system now that we've put these defaults directly into the electronic medical record so that when you do a surgery, let's say you're doing a laparoscopic appendectomy, you go to discharge the patient, the EMR knows you did a laparoscopic appendectomy, and so when you put in for a pain medicine, the default quantity that comes up is based on these recommendations. And we've seen some really great data around how that has overnight shifted the number of pills prescribed at discharge. Last, and certainly not least, is that we need to think about closing the loop around prescription writing and what patients are filling. And so first step is avoiding multiple prescribers. We now have a law around this, but the reality is that if you're prescribing a pain medication at discharge to a patient that already is getting pain medication from multiple other providers, you need to think differently than if this is a patient who's opioid naive or at least doesn't have chronic opioid use or isn't playing the system. The second is integrating all of these practices into your electronic medical record. One of the things that the laws did when they shifted to having them to be elevated security for writing certain prescriptions is that a lot of providers did not have access to write the prescription within their computer, so they had to handwrite it. And as soon as they were handwriting, they were nervous. Well, if this patient needs more pills, how do I get them a refill? How do I do that if they live far away? All of these very real concerns that are patient focused. And one of the things that we've done that I think really has been able to revolutionize the physician's comfort around lowering the default prescription and monitoring how many patients are getting is linking the ability to give an electronic prescription to opioids. And right now we can write for fewer numbers because if someone calls me on a Saturday, I can log into the EMR, I can send them an electronic prescription to their local CVS. And last and certainly not least, a passion of both mine and Julie's is how do we make disposal of these medications easier? I think we are making progress. We've gone from 30 pills for a lap epi to 20 pills to 10 pills, and folks they are not reporting increased pain. They're not reporting decreased satisfaction. We haven't seen increased phone calls to our providers saying they need more refills. But nonetheless, most patients still have leftover medications, and as close as we may come, we may never get to a point where we're specifically saying, okay, this patient needs 3, this patient needs 6, and that's exactly what they use. So there's probably always going to be a need for making sure that those opioid medications are disposed of correctly. So we have integrated this into our clinical practice. In my clinic, we have the box on the left of your screen. That box sits in our clinic, and so when they come in preoperatively, they see it. When they come in postoperatively, they can throw them away. And it's integrated into sort of all aspects of care that here we provide a safe and easy method for disposal. There are now envelopes and other systems out there that have debatable risks to our environment, but certainly are safer than just simply throwing them away in the trash can. And this is an area where we really think we need to do more. And the other component of making disposal easy is that gives us the information about how many pills people use. And that's an important part of closing that loop. If we prescribe 30 and we're worried that our patients need all 30, we don't really know or get satisfaction that those patients didn't need that until they come in and repeatedly tell us, oh no, they only took 5. Well, now I feel much more comfortable decreasing the number that I'm writing for because I have the data to support that. So ISQIC is our Illinois Surgical Quality Improvement Collaborative. We've created a toolkit to show everybody in other hospitals how to implement all these strategies. The toolkit is available on our website. It's currently, I believe, 57 hospitals, but it's always fluctuating a little bit. It is surgery focused, but here's our toolkit. As I said, it's on our ISQIC website. All of our opioid reduction strategies are on that, and all of our prior WebExes. We do a monthly WebEx around opioid strategies, reducing opioid prescription writing at discharge, integrating your EMR with the Illinois PMP. And those are also available, the historic ones, for download if anyone wants to watch that. With that, thank you very much. I really appreciate the opportunity to present our work thus far, and thank you everyone for signing in. I'd be happy to take questions.
Thank you, Jonah. Thank you, Julie. While we see about questions that we receive from our audience, can you mention the website address that folks can go to if they want to?
Oh, sure, absolutely. Yeah, I didn't realize.
I didn't
wasn't on the
see it.
slides.
I
Yes.
didn't see it.
Sure. So it is simply ISQIC, ISQIC, just like on this toolkit, ISQIC.org. We have several quality improvement projects that are highlighted on that. There's more about our collaborative on that. I believe the toolkit is then / opioid reduction initiatives, but it should be very easy to find from that main page. You just go, there's a menu bar on the left that says initiatives, and then when you hover over initiatives, you'll see our venous thromboembolism and surgical site infection, but opioid is part of that.
Okay, great.
And you know what? I'll put it in the chat box as well for people.
Okay, super. While we wait for some questions to come in, I was wondering if you might talk a little bit about how your work dovetails with other work going on nationally. I haven't asked you, but I just wanted to see. It might be helpful because, as we know, there's lots of initiatives at all different levels, at a local, state, national level going on, and I kind of was curious for the audience to hear what the connections might be or might not be between the work that you're doing and others.
Sure. So I'm happy to start, and then if Julie wants to jump in and complement that. So I sit on the Opioid Reduction Task Force as part of the American College of Surgeons. As part of so through that, I share all of our information with them, and then they have a large panel of individuals from across the country that weigh in, and they have patient education materials that they've developed and some work that they're doing. Our R34 grant that we talked about from NIDA actually has formal partnership with the American Hospital Association, the Illinois Department of Public Health, the Chicago Department of Public Health. And so they all sit on what's called an advisory committee to our grant. They give us feedback about it, and they help us stay aligned with other local, regional, statewide, and national initiatives that are playing out. There are a ton of different groups that are working on various strategies to attack, I think is probably the appropriate word, the opioid crisis from many different angles, from those who are studying those that are addicted to drug abuse and those that had recent overdoses, to those that are way upstream like us, trying to really approach prescription writing at the point of discharge. And so we try very hard to make sure that others know about our initiatives, what we're doing, and that we try and learn from others and hear about what they're doing, and make sure that the work from different organizations feeds each other and learns from each other. Julie, did you want to elaborate?
I don't really have anything to add to that. I mean, I think there's so much that's going on. I mean, even, in our interviews we did with our hospital system, our intervention isn't the only thing that our hospitals were involved in. So some are, taking things into their own hands to work on solutions, at their community level, as well at the hospital level. Lots of efforts around ways to reduce diversion and take back programs and getting kiosks into community pharmacies as well as ones into their hospitals. So there's a lot of stuff going on out there, and I'm sure our people who are listening could also provide some examples of things that they're doing or that they've heard of.
Okay, so let's see what questions we may get. I've have the chat window open. While we're waiting for any questions to come in, I was wondering what your thoughts are in terms of kind of the different levels of effort that are going on out there. Okay, we do have a question. I'll go ahead and it is, I'll read it out loud for you to respond to, and it's, do you have any concerns about putting the drop box in a clinic where there is no pharmacy?
Right, so yes, unfortunately. So the short answer is that prior to the DEA final rule in 2014, you were not allowed to have drug retrieval locations outside of police facilities. As of the final rule, the DEA final rule in 2014, it allowed for any organizations with a distribution license to apply for a retrieval license. So what that means is that all current drop boxes, or these opioid disposal kiosks, drug return boxes, whatever you want to call them, all of them have to be linked to a pharmacy retrieval license and therefore a pharmacy. Our clinics that were able to put these drop boxes in are part of our hospital defined area and therefore can have these. So the lobbies of hospitals are fine when you have an inpatient pharmacy that applies for the retrieval license, or if you have a commercial pharmacy that's on site, then you can talk about that, but it can't be at a location that doesn't have an on-site pharmacy. I will tell you that I am part of, and I'm working towards lobbying efforts to try and relax that even further. There are some legal concerns as to why they would, but the intent is clearly there from the DEA and from our law enforcement colleagues to try and make it more ubiquitous, that it's easy to throw away these pills just when you go to the shopping mall or where you go to your local communities. But as of right now, the law is such that it has to be affiliated with a distributor or a pharmacy.
Okay.
Thank you for that question. All right.
You see the follow-up?
Sure. So I'll just repeat the question then. The question was, what challenges do you see in getting reports from the EMR on default quantities? We worked for months. It took a long time to figure out how to get these reports completed. And so there were a lot of challenges. I think chief among them are defining the interaction that quote unquote counts. The CPT codes were created to estimate the work that went into the surgical procedure itself and not necessarily the pain that was caused from that surgical procedure. So some CPT codes would lump things that would be quite painful with things that wouldn't be that painful. And then, so furthermore, it kind of became difficult to say, okay, there are certain ones that are quite straightforward. Laparoscopic cholecystectomy, very separate from open cholecystectomy. That's an easy one. But there are many codes under laparoscopic cholecystectomy, like whether you did an intraoperative cholangiogram and all the rest of it. Should they all be lumped together? Should they be separate? How do you do that? So there, a lot of what I would say challenges came in the development of identifying the CPT code and identifying the opioids that were actually prescribed at the point of discharge, as opposed to all of those that came from an individual encounter. So if you're in house for 7 days and you were taking Percocet while you were in house, but then when you were prescribed Percocet, how do you separate the one that was prescribed at the point of discharge from the other? But most of those are technical and analytic in nature. And actually, I'd be happy to share sort of how we did it as a template to get people going if that's of interest. The next question that came in, which is a great one, willing to share provider modules for education? Yes, yes, yes. We would love to. Anyone who's interested, we would love to make them as available as possible. We're working on a format that's shareable. Right now, the format is internal LMS system built, but we know that it is possible to get it to be shareable and hosted more broadly, and we are working diligently on trying to figure out how to get that done.
Okay, that's great. I think the formatting that you're talking about is SCORM.
There you go. Yes.
So for those of anyone who's listening that's familiar with learning management systems, so it's somewhat, the content is the same and it's platform agnostic if it's put in SCORM. So we'll provide an update as you can to our members and let them know. So
great. That would be wonderful.
And then I think we have two more questions. Well, I think we have that question. But then I think if our presenters are amenable to this, besides the recorded webinar that we can provide your slides or some version of them to attendees off of our website, if that's all right.
Yes, I'm perfectly willing to share the slides.
Okay. And
Yes, me too.
all right, and what we'll probably do is, because these are really valuable website addresses that you've put into the chat, we'll put those addresses right in the slides themselves, so that people will have access to that after the webinar. So
there was a question about, please share how you went about the EMR reports or defaults. So what I would tell you is, within the ISQUIC toolkit, the default numbers are in there. The data from where we got those default numbers are in there, and some of the grouping information is there. If you're getting to the point where you're talking to an EMR programmer or an analyst or anything like that, and that's where you need help, just reach out to me at my email and we can get you connected with the right people.
okay. All right, we're at the top of the hour. If you can hang on for one more minute, I think we had one last question that I'd love you to look at. I don't know if you've seen it. It's not in the chat. It's in our Q&A, and that is, patient satisfaction scoring has led to a focus on patient pain control for hospitals and undervalue-based purchasing. Satisfaction scores are impacting dollars received. How do you see CMS addressing this issue under value-based purchasing? The Joint Commission is also has culpability in this issue due to years of surveys citing lack of pain control. How is that stance to be reconciled with the current situation?
Julie, did you want to tackle that? Or do you like me?
That's a hard one. That's a hard one, Jonah.
I give you the hard ones. I took the easy ones.
Yeah, I mean, I think we have to come to grips with this, right? I mean, I think it's about starting to have this conversation, you know, and changing the culture. So this will take time, I think, is the answer, unless Jonah knows that somebody is working on this immediately. But I think it will change, but it will take time, because we have to change the culture around pain control and setting expectations. But I think it will happen. So, but I don't know that this is an easy answer that we can point to someone who is who's addressing this, unless Jonah knows.
Right. Well, so I would just mention two things. One is that there is a recognition from CMS and other organizations that the questions that they previously had about pain control were not capturing what they had hoped for it to capture, and were not representing what they had hoped that it would represent. And my understanding is that there are movements to remove the pain control and pain components from HCAHPS, as well as other surveys. The other thing that I would say is that if you go and look at pain-reported outcomes over the last 10 years, you see little to no change. But what you do see is a massive increase in our reliance on opioids to treat pain. And so for those who are pushing back saying, well, I need to continue to prescribe this amount because of patient satisfaction questions, you can point them to the data that says there really has not been shown any clear link between the number of pills that you give and opioids and patient satisfaction. Now, a lot of people will come back to you on that and say, well, anecdotally, I had X patient or Y patient or whatever. And that does get a bit contentious. And I think that's where we have to fall back on exactly what Julie said, which is these things take time. There's a whole culture that has built up over the course of the last 10 years plus around how we treat pain and patients' expectations about how pain would be treated and how much pain they would have. And it will take time to change all of that. It won't be something that's overnight. And, you know, there are some patients who aren't going to give you the top satisfaction score pretty much no matter what you do. And so at the end of the day, we have to do what's right for the patient, and we have to do what's right for our community. And if that means that a patient or two doesn't like you as much as they would if you gave them a lot of pills, then so be it. But that's going to take time. So.
Well, thank you very much, Dr. Stulberg and Dr. Johnson, for being with us today and conducting this webinar. I think it's been really wonderful to get your experience and insight to what you've been doing, and your willingness to share the materials with our audience. And thank you to our audience for hanging in there the whole hour with us. And we'll get the word out as soon as the recording and the slides are available on the website. And that concludes our webinar today. Thank you.
Thank you so much.
Thank you.